So we are going to go to Dr. Kadro, who's going to give his tips and tricks for step-by-step crossing of aorto-iliac CTO. Dr. Kadro is a very, very accomplished operator, interventional cardiologist and endovascular specialist in the Middle East, and also a great academician, and we'll be very enlightened by his talk. To Dr. Kadro, please.
So the initial approach to aorto-iliac occlusive disease is try to determine the etiology if possible and determine if there are any side branches that should not be compromised. And what I mean by that, whether the contralateral common iliac or the internal iliac, in some cases that we need to prevent and try to not to compromise the inferior mesenteric artery and the renals, definitely. And also we need to determine the preferable axis and wire direction, and then evaluate the distal part for the re-entry segment. The anatomy of the aorto-iliac chronic total occlusion, if we determine the underlying factor, whether it's atherosclerotic difference when there is thrombosis or embolism, and whether there is aneurysm or not. The important variable in atherosclerosis disease is the location in the reference to the renal artery and the importance of the inferior mesenteric artery, as I said. The calcification also affect our decision how to cross, and the amount of the thrombus, whether we need to do thrombus aspiration before.
Dr. Kadro, sorry to interrupt. Hello.
Yes.
So we still can't move see your slides move or the slideshow mode. So can you please move the arrow keys like you did before?
Okay, this is good. Can you see the slides?
Yes, sir.
Okay, so the amount of the calcification and amount of the thrombus may affect our the decision how to cross and how to finish the intervention. So the access site selection, we have general consideration. If it's we'll try to determine the access site depending on the preoperative imaging, whether if there is CTA or MRA. So usually we perform angiography from the retrograde common femoral artery contralateral to the more symptomatic diseased limb. That's in the absence of pre-op imaging. Location and the nature of the lesion in the is the primary determinants of the access approach. So if there is common iliac artery stenosis, the approach is clear from retrograde from the ipsilateral common femoral artery. If there is proximal common iliac artery CTO, chronic total occlusion, we try to approach from anterograde, whether the brachial or the radial artery. If there is external iliac artery CTO, the approach is from the contralateral common femoral artery, crossing over and then do the intervention. If there is external iliac artery CTO, we need to approach that from the radial or the brachial if there is prior aortic bifemoral surgery or EVAR procedure in the past, or kissing aorto-iliac stents or tortuosity. So for that, although the CTO in the external iliac, but that's definitely the radial approach is the best. Now the access, to get the access, always try to use ultrasound guided with micropuncture kit. Alternatively, may go directly to 5 French or 6 French sheaths from the radial axis. But always try to do ultrasound guided if you are going through the femoral. The radial axis for the iliac intervention has some advantages. It has less vascular complication, avoid the diseased common femoral artery, early ambulation and shorter hospital stay, easy hemostasis, and more comfortable to the patient. However, there are some disadvantages: limited vessel size, spasm and tortuosity, limited equipment lengths, and limited therapy option due to small vessel and sheath size. So always before deciding to go from the radial, try to know your distance and measure the distance. And I'm not going to mention those distance, but try to review this slide and get approximation about the distance, so you can know the size, the size and the length of the sheath, and the size and the length of the balloon shaft that you are going to do. And there is increased radial availability of all equipments from different company. There are now 6 French sheaths with the lengths exceeding 1 meter, now reaching 120 centimeter. There are 2 centimeter balloon now. There are 6.5 French sheathless guiding catheter from the radial for better dilation and better lumen. As we said, try to measure the distance and try to remember those equipments, and depend on the 260 centimeter stiff glide wire and 300 centimeter super core wires. I'm going to give you some case example, and we can do further discussion. This is the patient referred for peripheral intervention of the left iliac instant CTO, instant total occlusion. So we put this pigtail from the radial and did the angiogram. And from the radial, we were able, you see that, to cross and go through the stent and do dilation. And we used the 3 centimeter super core wire, 6 French 110 centimeter shuttle sheath, 260 centimeter stiff glide, 8 centimeter PTA balloon for the instant restenosis. And this is the result, and we got very good result on both sides. So let's see another case quickly. This is a 63-year-old female smoker with high blood pressure, hyperlipidemia, and severe right and mild left thigh claudication after walking only 1 block. Her rest ABI is 0.65 on the right and 0.97 on the left, and no drop after 5 minutes of exercise. So she was referred for this angiography and intervention. And this is a calcified subtotal left common iliac stenosis, and there is right common iliac CTO with that. So, and you see, this is the length of the CTO. So we went from the left side, and so how would you approach this CTO? Is from the common femoral artery retrograde, or the left contralateral, or anterograde from the radial? So we put under ultrasound guidance sheath in the right common femoral artery, and we tried to go retrograde, but it went subintimal. So, so it wasn't successful. So we tried from the sheath from the left side and tried to enter, but there is no adequate support. So we could not penetrate the gap or the cap of the total occlusion. So we tried to use reverse Kerr catheter with this tip, still no backup, and we cannot penetrate. So we learned our lessons, so and we put left brachial sheath, and with that, quickly we were able to, because of good support, we were able to cross this total occlusion, and then with some more intervention. But we are required to snare that wire from the femorals to get better support, and then we did the PTA, and then kissing stent, and balloon expandable stent, and one self-expandable stent. And this is the pre, and this is the final. We got very good results. So that's, we learned our lesson that for this, radial was the best approach. Another case, this is a 60-year-old morbidly obese male with past medical history of tobacco abuse, high blood pressure, hyperlipidemia, and sleep apnea with the diastolic heart failure, atrial fibrillation, He had prior stroke with severe disabling claudication. Found on prior angiogram to have left external iliac CTO with 2 prior unsuccessful attempts to cross. So this is, you see that this is the total occlusion, and this is the length total occlusion. The infrainguinal vessel was really patent, so there is no problem. It is disease, but there is no significant stenosis. And look at this run off down below the knee. So this is the total occlusion in the left external iliac artery. So how would you approach this CTO? So we under ultrasound guidance, we put in the right common femoral artery axis. So that's from the contralateral side. And then we use soft glide wire and put the glide wire and went into the internal iliac artery on the left side. And with that, with the support, because the wire is in the left internal, we were able to put crossover sheaths. And once we delivered the crossover sheaths, then we switched to stiff glide wire, and we're able now to penetrate and then crossed, and then do further stenting, PTA, and then put stent and self-expander stent. This is the pre, and this is the final, and this is the good run-off. So I still have time for another case. This is a 68-year-old female smoker with high blood pressure, hyperlipidemia, and diabetes, referred for right calf claudication that progressed to the thigh and the buttock, and now only able to walk less than 5 minutes. Her peripheral vascular study showed right iliofemoral disease was drop in the ABI from 0.59 to 0.29 after 1 minute of exercise. So this is there is a right external iliac artery total occlusion. That's the common iliac, and that's the right, and this is the common femoral artery. So, so how would you approach that? This is a CTO. With that, there is no peak for anterograde crossing. Even if we do further angiogram, you could not see the peak of that. So anyway, we use the ultrasound guide to put micropuncture in the right common femoral artery. That's ipsilateral for the CTO. And we put the wire on one of the branches, that the circumflex branches of this external iliac, just to anchor the sheath and introduce small sheaths. And then we were able to use the 14 wire and cross ipsilateral retrograde. And then once we cross the CTO, and this is should show an angiogram. Anyway, you asked me not to use the presentation mode. So this is the PTA, and then we were able to stent. This is the post. So we compared the pre and the post that we opened the total occlusion. I think still I have time for the last case. This is a 71 obese female smoker with high blood pressure, hyperlipidemia, and COPD. They found to have a critical internal carotid artery stenosis, but she was referred for a carotid stenting, but had severe claudication and the ABI was 0.5 with duplex showing right iliac and left SFA stenosis. So with this anatomy, we deferred we cannot go and do carotid intervention. So this is the right common iliac artery, CTO, and we tried just from retrograde by doing micropuncture. We were only subintimal. So we had to learn our lesson and take our medicine. And so we went from the contralateral, the common femoral artery, retrograde, and there is here a stump for this CTO. And it is a little bit long CTO, but since there is stump, that will give us adequate support. So with that, we were able to put the catheter, get support, and then cross, and then do the final thing, and just snare the wire from the right side and do further intervention. So this is a balloon expandable stent and another self-expandable stent, and we got good result. Let's see. Yeah, this is the final angiogram. I put it by DSA, and you see good result run off on both sides. So I think I did show you enough cases. I'm not gonna skip the last case just for the sake of time, and just put the summary again that I mentioned step. Always use ultrasound micropuncture, pre-op imaging, helpful to plan your case. Location and nature of the region, the primary determinant of the access approach. Common iliac artery stenosis approach from the retrograde ipsilateral. If there is external iliac artery stenosis, try to approach from the contralateral. Proximal common iliac artery CTO approach from anterograde from above, whether it is the brachial or the radial, and external iliac artery CTO approach from the contralateral common femoral artery, because there is adequate support you can cross. If there is any previous intervention or EVAR or previous aortoiliac stent, the best way is to approach from the radial or the brachial. Thank you very much for your attention.
There, and we are going to come back to all of you for discussion.